Go ahead, Mr. Prorector.
Okay. Hereby, I open this academic ceremony in which Emara Nabi will defend the academic thesis, Parental Tobacco Use, Dual Use of e-cigarettes and cigarettes, and interventions to help them quit. May I invite you to present the summary of your study and the conclusions of your thesis.
Thank you very much, dear Prorector. I will share my screen now. Dear Prorector, dear highly esteemed members of the Corona, dear family and friends present in the audience today and watching the live stream, thank you very much for joining me in the defense of my dissertation entitled Parental Tobacco Use, Dual Use of e-cigarettes and cigarettes and Interventions to Help Them Quit. I will start the presentation by looking at some background information. Most of us here know everything, but just to orient ourselves why this research is important. According to World Health Organization, tobacco use is the single greatest preventable cause of mortality, killing more than 8 million people each year. The tobacco product landscape has changed and continues to change with new and emerging products. In the last 15 years or so, the use of electronic cigarettes, or e-cigarettes as they are popularly known, has increased globally. E-cigarettes are marketed as less harmful alternatives to cigarettes, but their long-term effects on health are not fully understood. Most adults who use e-cigarettes also continue to smoke cigarettes and are considered as dual users. So this dual user is an outcome of e-cigarette use that we are interested to study in this thesis, because we found that there is a gap in the knowledge about understanding dual use as a behavior. A quick look at why we need to address parental dual use. So dual use or smoking parents are a unique and special population, as their behavior not only exposes themselves to the harms of smoking and vaping, but also exposes their children to the harms of smoke and e-cigarette aerosols. Other than the well-documented effects of tobacco smoke on children's health, these children are also at an increased risk of initiating smoking at a later age. Dual use is particularly harmful in parents as it could lead to renormalization of smoking or could be a potential gateway to smoking or e-cigarette use for youth. In the context of the child healthcare setting, pediatric healthcare providers are uniquely positioned to motivate smoking and dual user parents to quit and provide effective evidence-based assistance to them. After the background, let's take a look at the research questions that this dissertation aimed to answer. On this screen, we see the research questions and the chapters in which they're addressed in the thesis. The first question was looking at the factors associated with dual use of cigarettes and e-cigarettes in the parent population. The results of this analysis in the context of a widespread marketing of e-cigarettes as a smoking cessation aid led to our research question 2 about current evidence on long-term smoking cessation between dual users and cigarette-only smokers. The findings from these 2 chapters led us to our research question 3, that is about the rates of receipt of smoking cessation treatment among parents who are dual users compared to cigarette-only smokers when it is offered. Chapters 5 and 6 look at the data from the randomized control trial Cs. Chapter 5 looked at the qualitative data about the factors that influence the implementation of a smoking cessation intervention in the pediatric setting. And finally, Chapter 6 looked at the implementation and sustainability of a tobacco control intervention in the pediatric setting. 4 of these chapters have already been published in peer-reviewed journals, and 1 chapter is provisionally accepted. In the next 10 minutes or so, I will aim to present the results from these chapters. In Chapter 2, we looked at the exit interview data from 727 current smokers after their visit to the child pediatric primary care setting. The exit interview survey asked these parents questions about their smoking behavior, including frequency of use, readiness to quit attempts in the past 3 months. Of these 727 smokers, 11.1% also reported e-cigarette use, and these were the dual users. In our analysis, we found that compared to cigarette-only smokers, dual users were more likely to have a younger child, less than 1 year old. The possible reasons for this could include the desire to quit smoking with a child who's young, or a belief that exposure to e-cigarettes is safer than cigarettes. We also saw that these dual users were more likely to plan a quit in the next 6 months, or had tried to quit in the past 3 months, which was assessed by using the questions about their quit attempt in the past 3 months, or if they had used a quit line or medication in the past 2 years. So these findings are consistent with findings from other studies like the Nayak or the Pascal study, which show that dual users are significantly more likely than exclusive cigarette smokers to have made a quit attempt or have an intention to quit smoking. The results from this analysis suggested that parents who use both e-cigarettes and cigarettes may have higher rates of contemplating smoking cessation than parents who only smoke cigarettes. They could be using it for harm reduction or as a step towards cessation. In Chapter 3, we aim to look at the current evidence about the association between dual use and long-term smoking cessation among adult smokers. We included prospective cohort studies with at least 1 year of follow-up and studies that had dual use of cigarettes and e-cigarettes at baseline. The primary endpoint was cigarette smoking cessation 12 months or later. The electronic search retrieved 4,725 results, and after removal of duplicates, review of titles and abstracts, 16 full text articles were retrieved and screened for inclusion in the review. 7 of these 16 articles were excluded because they did not either have the comparison of dual users versus cigarette smokers, or did not include smoking cessation as an outcome. So in total, 9 population-based longitudinal studies were included in the review. Of these, 7 reported odds ratios, and these were included in the meta-analysis that I'm going to present now. We computed pooled estimates of the odds of smoking cessation among dual users compared to cigarette-only smokers using a random effects meta-analysis. In the meta-analysis, we found that dual users were not more likely to have successfully quit smoking at or after 1 year compared to cigarette-only smokers. And we did not find any evidence of publication bias in this. In the other analysis, as a secondary analysis, we looked to assess the changes in nicotine product use among dual users at 1 year follow-up. We used the random pooled effect size to do this analysis and found that of the 773 dual users at baseline, at 1 year follow-up, 86.2% were still smoking. 6.4% were using only cigarettes, and 7.2% reported quitting all products. Based on this analysis, we concluded that majority of dual users continue to smoke after 1 year of follow-up. So the second and the third chapter of this thesis suggested that dual users of cigarettes and e-cigarettes may have a unique population who probably start using e-cigarettes as they are contemplating smoking cessation, but in the long term may not end up quitting smoking and may become dual users of cigarettes and e-cigarettes. These findings led us to the next 3 chapters, which is about the delivery of evidence-based smoking cessation treatments in pediatric healthcare settings. In the next 3 chapters, we will look at data from the SEASE trial. SEASE stands for Clinical Effort Against Secondhand Smoke Exposure. It is a tobacco control intervention in the pediatric health setting. So SEASE uses the Ask, Assess, Refill approach, where families are screened for tobacco use using a pre-visit questionnaire. They're offered to set a quit date and offered help by offering nicotine replacement therapy and referral to the tobacco quit line and or a texting program to help them quit. And if they are interested, they are given the medications are delivered to them, and quitline and smoke-free text enrollments are done automatically for these parents. So results from this trial, the chapter 4 focused on receipt of treatment for dual user parents. In this chapter, we found that 804 parents reported using cigarettes, out of which 722 reported current use of cigarettes only, 111 reported using e-cigarettes. And 82 of these reported using cigarettes as well. So 82 met the definition of dual users. We compared them with 722 who reported using cigarettes only. We found that parents were more likely to report receiving any treatment if they were dual users versus cigarette-only smokers. So this data suggests that dual users who visited the intervention practices were more likely to receive treatment than cigarette-only smokers when treatments were discussed or offered. In the last two chapters, we'll look at the data from the thesis trial. In chapter 5, we will look at some qualitative data. We conducted semi-structured qualitative interviews with the practice leader or the practice champion at the intervention practice and the study coordinator 2 years after the intervention was implemented in their practice. We used the CIFA framework to develop the interview guide. An interview codebook was inductively developed. Two researchers, one of them being myself, used the codebook to code data. And after coding, data was analyzed to identify factors which were described by the 5 CIFA domains. So these are the factors that we found influenced the intervention implementation. Using the 5 CIFA domains, we found that the implementation was influenced by how adaptable and complex the intervention was, by the needs of patients and their families, by the resources that were available to the practices outside of their practice, like the free tobacco state quit line, also by the competing priorities at the practice, the culture at the practices, and the clinicians and office staff knowledge about beliefs about family-centered tobacco control. The engagement of the practice staff and the practice champion also influenced the implementation of the intervention. So as part of the RCT, 10 pediatric practices in 5 states were randomized to either cease or usual care control. Our primary outcome was to assess delivery of meaningful tobacco treatment, which was defined as prescription of nicotine replacement therapy or quitline enrollment in control versus intervention practices. And as a secondary outcome, we aim to assess the change in practice level smoking prevalence and cotinine confirmed quit rates over 2 years of intervention implementation. The results showed that the rates of treatment delivery was significantly higher in the intervention arm compared to the control arm. Right after intervention implementation, the delivery of treatment was 44.3% in the intervention versus 0.1% in the control arm. And 2 years later, even the percentage had dropped, but the intervention was still implemented in the intervention practices with 14.1% smokers receiving treatment for their smoking and 0.3% in control. This demonstrated that the intervention could be delivered and sustained over 2 years. In terms of the secondary outcome, we found that over the 2-year period, intervention practices had a 2.7% decrease in parent smoking rate compared to a 1.1% increase in control practices. We found similar results for the cotinine confirmed quit rates, which were also higher in the intervention arm compared to the control arm. So this is the conclusion of the chapters. And just a quick look at the conclusions that we have looked at, we found that dual users may be more likely to contemplate smoking cessation than cigarette-only smokers. Majority of dual users continue to smoke cigarettes after at least 1 year of follow-up, either as dual users or exclusive cigarette smokers. And dual users may accept evidence-based treatment when it's offered in a healthcare setting. And evidence-based treatments can be effectively offered to parents in the child primary care setting. Before I end, I would like to thank my supervisors, Professor Zegers, Professor Winnikoff, and Professor Williamson, without whom this thesis would not have been possible. Thank you so much for your attention. I will now give the floor back to the prorector.
Thank you for your presentation. The opposition will now be opened by Professor Nagelhout, Professor of Health and Well-being of People with a Lower Socioeconomic Position at the Maastricht University. Professor Nagelhout was chairman of the assessment committee, and she is the secretary of the degree committee. Professor Nagelhout.
Thank you. Dear candidates, I would like to start with congratulating you and also your supervisors with completing your PhD thesis on such an important topic. Parental tobacco use and e-cigarette use are both topics that a lot of people worry about. And therefore, I think it's really important that you have done studies into this subject so we can more effectively help people to quit smoking. But of course, I also have some questions for you. In particular, I would like to discuss chapter 3 about your systematic review and your meta-analysis. And I would like to go to the abstract first. It's on page 34 of your printed thesis. And you write as an implication of your study in the abstract that each e-cigarette should not be promoted for cigarette smoking cessation. And although I'm sure that many would agree with that, that statement, I am not sure that it really is an implication of your study. Can you explain how you can draw this conclusion with the inclusion criteria that you used in your review and the analysis that you performed in this chapter?
Thank you very much, highly esteemed opponent, for that question. Yes, I agree with you. Tobacco and tobacco use in general is something that we all want to address. Coming back to the systematic review, so one of the implications, as you mentioned, was that these e-cigarettes should not be promoted for cigarette cessation as consumer products. When we looked in the systematic review, we found that these people who start using e-cigarettes, they were probably starting to use they probably used these e-cigarettes to stop using their cigarettes. But in the long term, after 1 year, we saw that most of these smokers had not quit smoking. They were either dual users or cigarette users exclusively. There have been many studies, there have been some trials that have shown the potential benefit of e-cigarettes in a controlled setting, in a prescribed setting. But all these results from the longitudinal studies that we saw showed that we did not see real cessation of these smokers. There were some good studies that we looked at, but none of them really looked at cessation. And when none of them proved that these people had quit tobacco products or e-cigarettes at the end of that 1 year.
Can I stop you for a minute?
Yeah.
Because I'm not really addressing the cessation part or the long-term part or the RCT versus observational, but more the study group that you used, the inclusion criteria that you had, because you only examined dual users. So can you then draw conclusions about whether it's an effective smoking cessation aid?
Yes, highly esteemed opponent, I see your point, and I do agree that e-cigarettes, in the population that we looked at, be it the 7 studies we looked in the meta-analysis, where we looked at the quit rates of these people who were using e-cigarettes for cessation, at the end of that time, we did not really any of these studies did not show that dual use. Our claim was about dual use, and the implication is that as consumer products in the general population, in the real world, e-cigarettes probably should not be promoted as cessation tools unless there is evidence that shows that they can be successfully used in the real world as a consumer product that helps.
But there could still be an effect among the people who switch to e-cigarettes and are not dual users, right? You only examined the people who remained using e-cigarettes, so probably the ones who were not that successful in doing what they intended to do.
That's a very good point, and that is a point that we did think about. But our goal here was to look at dual users exclusively as an outcome. E-cigarette use could have multiple outcomes. It could have an outcome of a person becoming a dual user. And as you say, one point was cessation, where they would have quit smoking, and the other would be exclusive e-cigarette use. We chose looking at dual use as an outcome. And based on that, we are saying, and we say that at the moment, with the evidence that is out there, they should not be promoted as cessation tools.
Okay, thank you. I have another question that's more into the statistics of this. Well, it's not really deep into the statistics, but of this same chapter. Because at the end of the results section of part 1 of the results section, so at top of page 40, yeah. It says dual use of e-cigarettes was not associated, or no, sorry. The meta-analysis showed that dual users were not more likely to have successfully quit smoking at or after 1 year compared to tobacco cigarette-only smokers. And since you used the word not, I assumed that the association was not significant. And you also give an odds ratio that doesn't seem to be significant, but then the p-value is significant. So can you explain to me how I should read this?
Yes, that is a great point, dear esteemed opponent. And the p-value there at that place was for the I2 statistic, which was to assess the heterogeneity. So my apologies for not making it clear in the text and not making it clear that that p-value is for the heterogeneity of the meta-analysis, which was about 76%. So the p-value was significant for the I2 statistic.
Okay, I understand. Pro-Rector, do I have time for another small question?
Yes. Yeah,
also, in the results section of this same chapter, you have a heading number 1, and the title of the heading is dual use of e-cigarettes was not associated with lower odds of quitting compared with exclusive smoking. And then in the first paragraph below that heading, you say dual users did not have greater odds of quitting cigarettes compared to cigarette users only. So I wonder why you use lower and then greater. And didn't you just examine whether there was an association, or did you have an hypothesis or a certain test that did look at the direction of effects?
Again, another great point, which I did consider when I was writing this. When I was writing the details about the paper, the Manzoli paper, this comment of yours refers to the Manzoli 2015 and 2016 papers. When I was writing about those, I tried to put in the language that was in the papers to reflect that how did they present the statistic. Our hypothesis going in was the dual users likely do not quit smoking in the long term, which is more than after 1 year of cessation. We had looked at many studies which looked at 6 months or less than that, and some which looked at more than 6 months of cessation. But so in the text, we presented findings that were, that's how the Manzoli paper presented it, to just replicate what they published in their paper.
Okay, thank you very much for the clarification. I give the word back to the Pro-Rector.
Thank you so much.
The opposition will be continued by Professor Wilson, Professor of Pediatrics at the University of Rochester Medical Center in New York, and Professor Wilson was also a member of the assessment committee. Professor Wilson.
Thank you very much, Pro-Rector, and congratulations to you, the candidate, for a really outstanding presentation on a very, very important topic. As you know, this is something that I care very deeply about and have thought a lot about. I was impressed by the strategic and very specific and systematic way that you were able to introduce this evidence base and take it from, the systematic review through data collection to look at how this would inform prevention or intervention. And I'm wondering, as I think you were aware, I'm also very interested in the co-use of marijuana and tobacco. And that's something that we're recognizing is much more common, I think, than people have seen before. And it's becoming more common with legalization of marijuana. And I'm wondering how you think you could apply what you have learned about e-cigarettes and combustible tobacco co-use in advancing our understanding of marijuana and tobacco co-use.
Thank you very much, highly esteemed opponent, for that question. I've read a lot about your work about with e-cigarettes, cigarettes, and now marijuana use. And when I was looking at the dual use of e-cigarettes, the marijuana use definitely came to mind. And definitely when I was reading literature about dual use, there were hints about the dual use of e-cigarettes with marijuana, how marijuana use, I won't say has probably increased, but e-cigarettes are the mode of using marijuana. So addressing it in the healthcare setting is very important, but since marijuana is not legal in many places, it becomes a bit difficult for people to self-report that they are using marijuana. So I would say if we see evidence of dual use, e-cigarette use, or any sort of substance that we hear from our patients, we should our radar for marijuana use should always be there. We should always aim at looking at the the patient's total abuse, the chances that they must be using some other product, and address what they are self-reporting, but keeping in mind that there could be other dual or poly use of tobacco and other products like marijuana with these people, and offer evidence-based treatments that we have currently to get them off these products.
Do you have any sense of what the intervention might need to be, how it might need to differ for parents who are co-using marijuana and tobacco versus the dual use of electronic cigarettes and tobacco?
Great question, great topic for a new grant, but I would think that starting with, in the pediatric setting at least, when we start in the pediatric setting, the intervention could begin by focusing the importance of not using these products for their children, the effects of these on their children. I'm talking about the pediatric population, and how if you're addressing this in the pediatric setting with these smokers, if they are teenagers or parents, the health implication of using the other product with these is not good. Any product in itself is not good, but using dual tobacco use is not good for the health of anyone, and especially children. So I would use that at least in the pediatric setting to address this dual use.
Right. Excellent. And then I have a second question, if I have time,
Yes.
on chapter 3. So in the systematic review, the dates of these go up to about 2020. And so the data is from probably the mid-2000s, it looks like, from the articles that were in there. And I'm wondering if you think that there is any, that there will be a difference in the findings today with the more high potency electronic cigarettes, so the ones that use the nicotine salt, and are able to deliver a higher nicotine dose to the person who's using it. Do you think that that we might find more cessation, more effectiveness of e-cigarette use with these newer products?
That is a very good point, dear esteemed opponent. And I have been, the systematic review is not published yet, but I have been, because of the interest in this topic, looking at different studies that have been coming out about dual use specifically. There are some papers or reviews about e-cigarettes leading to cessation, and there are lots of them. And a recent systematic review, the Cochrane review, suggested that there are potential potentially e-cigarettes could be used for cessation. But when you're looking at these dual users, my niche topic here was dual users, because this is a huge group of people. About 40% of these of the people who are using e-cigarettes are using tobacco or using cigarettes. So I haven't seen any new papers on this topic about dual users quitting smoking or in the long term. So the short answer is I haven't seen any, and I have been checking it.
Excellent. Thank you.
Thank you so much.
The opposition will be continued by Professor Kotz, Professor in General Practice with the main focus on addiction research and clinical epidemiology at the Medical Faculty of the Heinrich Heine University in Düsseldorf, Germany. Professor Kotz was also member of the assessment committee.
Thank you very much, Mr. Pro-Rector, and congratulations, dear candidate, on a very good thesis on a very relevant topic, and also on conducting such a complex trial on the thesis intervention. And my questions mainly relate to this trial and to chapter number 6 of your thesis. So in this chapter, you say at some point that the majority of clinical and support staff trained was conducted via phone, online learning courses, a training video, and a training manual. So we recently also did a trial in Germany where we trained general practitioners in providing brief advice for smoking cessation. And we also thought about this kind of remote training or online training because it has a lot of advantages, of course, delivering it that way, especially when you are across the different states in the US. But we decided not to do so because we thought when we want to train specific skills, specifically communication skills, we must do it in person and with simulation patients and so on. This is something which cannot be delivered very well in an online course, we thought, because we also during these trainings we realized how difficult even clinicians with 20 years of experience find it to clearly say to a patient, I recommend that you stop smoking, and I advise you to use this treatment, this medication. This really needs to be trained. So my question to you, my first question is, do you think that your training was sufficiently effective, the way you delivered it in and training these skills, particularly the communication skills needed to deliver the intervention?
Thank you very much, highly esteemed committee member, for that question. I will begin by saying that I've read your work in Germany and take a lot of inspiration from it. And about the thesis trial, yes, you are right. It took a lot of thinking. Professor Winikoff here is the PI and of the study, and it took us a lot of time and effort and a lot of iterations of Cs to come up with this training strategy. We wanted a tobacco control intervention that could be easily disseminated, and we couldn't cut ourselves into pieces to go into different places. So we thought of a strategy, as you have been thinking, in the right direction of online training. So it worked. You're right about the effectiveness of the training, and we were worried about it in the beginning, but we used a multimodal strategy. For example, as when you're talking about the communication, we worried that, yes, how would the clinicians communicate with parents? And we did a role play video where Dr. Winikoff was the clinician, and we had different kinds of scenarios in which smoking parents would come in the office, and that was a clue for the clinicians on how to address that situation. This helped with the dissemination of the intervention because the pediatricians or the clinicians could view that video whenever they wanted, whenever they had the time, not during the scheduled time. And when we did our qualitative interviews, one of the things that came up in those interviews was that how people appreciated the flexibility in the training, because They were really busy during their clinical times, in the clinical hours, but when they had time, they could view the presentation, they could view the training manual, or view the videos for that matter to get the information. We also gave them some FAQ sheets about using nicotine replacement therapy medication, because that is something that's not used commonly by the pediatric providers, and they found that particularly helpful when they were meeting with people. So this strategy worked for us. We had good feedback from all the clinicians about the training strategy.
Great. Second question is relates to the advice model, the ask, assist, refer model. And you say in the chapter that participating clinicians were trained to help interested smokers set a quit date, set smoke-free home and car rules, and encourage NRT use. So this reads to me as that there was no intervention in non-interested smokers. So probably you mean smokers were not motivated to quit at that moment of encounter. And well, that is probably a large proportion, at least in Germany, that's about 95% of all patients, actually. So is that true that this AAR intervention only works in motivated patients? Is that a disadvantage, or how does it work in practice?
So thank you, highly esteemed committee member, for that question. So what we did with the SEAS intervention, and what we do is people who are interested in smoking cessation before the visit are offered treatments like nicotine replacement therapy or referral to the quit lines. This happens before the visit. And if they're interested, even before seeing the clinician, they click yes, and they're automatically connected to the quit line smoke-free text service, and prescription is delivered to their house. For the
what proportion is interested?
32 to 40% of our population has been interested in NRT or any of these. But a really valid point from you about the people who are not interested. And a high number of people are not interested in these medications. And this is where the clinician training comes into effect. This is when we motivate them, if they're not ready at that time, to have smoke-free homes, vape-free homes, smoke-free and vape-free cars, to protect their children. And these people who are smokers get the survey every 3 months, which serves as a reminder for them to accept treatment, that the pediatrician is there to offer cessation treatment whenever they're ready. And we did see a lot of people may not have accepted treatment in the first time or the second time, but subsequently they have accepted treatment. So it's also when they are ready, at what stage they are. But the training includes offering help at all times and advising them to have smoke-free and vape-free environments for their children at the very least.
And Mr. Prorecker, do you have time for one last question?
Last short question, please.
Yes, that is about the real-time monitoring, which you implemented. So probably this kind of intensive monitoring would not be feasible if you roll out the intervention across the whole of the US. But with this monitoring, you had a rate of meaningful treatment delivery of 14% after 2 years. So how high would this percentage would have been without this real-time monitoring, you think? So how well can this intervention be rolled out without such a backup system? What do you think?
Thank you very much, highly esteemed committee member, for this question. I am really pleased to say that it's gotten much better now. What we have done now is gone a step ahead and integrated this pre-visit screening questionnaire into the IEHR, into the electronic medical record of the child. So now we are reaching levels of over 80% people getting the smoking screening survey before their visits, and they are completing it. There was a missing link at that time, that these surveys were not connected to the medical records of the children. But now we've covered that gap. That gap has narrowed down. We are delivering these pre-visit questionnaires through the electronic medical record of the child. And our real-time monitoring has become even better because we don't need to automatically, everyone has to do it, just like they would do the other screens for their children.
Fantastic. And I think we would love to have something like that in Germany as well. I hand back to the pro-rector.
Thank you.
Thank you.
The opposition will be continued by Dr. Reis, researcher and physician at the Department of Social Medicine at Maastricht University. Dr. Reis was also a member of the assessment committee.
Thank you. Dear candidate, my congratulations go out to you and your supervisors for this very relevant topic, because we need this knowledge and this practice to reach a so-called smoke-free generation, as we try in the Netherlands. And as a youth health physician, I am glad to have a small conversation with you on the implications for this daily practice. But first, I have a curious or clarification question, because in chapter 5, you describe how this CESE intervention, a program to make another program reach these parents, how you try to detect whether there is a smoking behavior in the home. And then even you also ask this question when the accompanying parent or caretaker isn't the smoker. So, but I'm curious what happens if the accompanying parent says, well, I'm not the smoker. What does this mean for follow-up visits or for the CESE intervention?
Thank you very much, esteemed member of the committee. And this is, I'm glad you brought it up, because this is what we have been thinking during that study and post that study. How do we get to these household smokers? Our goal is not just that person who's coming in. So the subsequent iterations of CESE, the first question we ask is, who in your family smokes tobacco? And then we give them options: only me, only somebody else, me and someone else, and then nobody. Like this, we get to the point that if it's this person or somebody else who is smoking tobacco, when they say me and someone else, we offer them treatment at that visit. But when they say only someone else, we have been pilot testing, getting the information about the other household member, just the information, and we have been pilot testing, contacting those people and asking if they would be happy to have a smoking cessation intervention or any sort of treatment if they're ready, if they need any help. So we have been thinking about it and trying to get some more data out there about this.
Oh, great. Well, looking forward to that data. Then I have another question. It's about chapter 4, in which you describe the treatment options for quitting, being discussed more often with parents who are identified as dual users, as opposed to cigarette-only smokers. And they also seem more likely to receive the treatment. But I'm curious, my curiosity goes out to the professionals. So how come that they bring up the topic more often with the parents who are identified as dual users, as opposed to the cigarette-only smokers? Can you elaborate on that a bit?
Thank you very much, esteemed committee member, on asking this question. When we started to even look at this analysis, we had the same questions: that what is happening here? What is different? And I think we think that these dual users may be more likely to want to quit smoking. They may be a step ahead in their journey of smoking cessation. And that's why when the clinician is bringing up the topic of smoking, they are the ones who are being responsive. They are the ones who are being, they seem more responsive to the offer of treatment. And that is why the clinician continues the conversation. For somebody, even in our training, if somebody is not that responsive, we don't want to put them off. So the clinicians don't then touch the topic topic in detail. So our hypothesis is that these are the people who seem more interested to the clinicians when they are asked about smoking. And that is why there is more discussion about treatments and there's more delivery of treatments to these people.
Yes, but the outcome measure wasn't if there was little or more discussion, but if it was brought up. So how does this being a dual smoker influence bringing up the discussion in the first place in the professionals? And what could we do with this knowledge?
I agree with you. We cannot say for sure that why was the discussion brought in, what happened in that exam room, but what we are trying to do is parse out what could have happened. The screener was filled by everyone and the clinicians had the information about everyone. So why is it that they are choosing these dual users? That was our thinking as well. But since we were not there, it was hard to know that why is the discussion more, but the only logical explanation could be that these people were interested in smoking cessation. They must have expressed some interest to the clinician that the discussion went forward as opposed to only cigarette smokers.
Oh, that's interesting. So probably an initiative in the parent because of the screener. That's an interesting viewpoint, because I was wondering maybe it came up in the qualitative study of chapter 5, I believe, but not so much. Otherwise, you would have told me right now.
The dual use did not come up that much, but our assumption is that it was after the screener, the parent was prompted to speak.
Exactly. Mr. Prorector, do you have time for one more question?
Very short.
Thank you. Because then I come back to our common goal of a smoke-free generation, and then as much praise as we all express sincerely for the RCT that you conducted with thesis, and that it is a significant effect. As a youth health physician, I find myself quite impatient if we have to await 2.7% before we gain this smoke-free generation. So have you got any ideas on how we can join forces to accelerate or, well, increase the effects of your work?
Absolutely. That is a really good point. We've been thinking about it. There are, other than the clinical implications that everyone should be screening families for tobacco use and offering assistance, we also think that there are some policy considerations that should be implemented at the same time. For example, e-cigarettes should be included in the smoke-free laws, and this could help decrease the use of e-cigarettes when they are used as a substitute for cigarettes when smoking is not allowed. Also, if there's better regulation around e-cigarette use or they are more standardized, the marketing of these e-cigarettes is, your worries about the next generation is the same as we worry about it. They are getting exposed to it. We think if there is better regulation of these products, there would be a decrease in the number of people who are uptaking these products. Another policy level implication could be that banning flavored cigarettes. And I just read that the Netherlands just came up with the law of banning flavored cigarettes from next year, October 1st. I think in general, these sort of policy considerations and maybe including the minimum sales age laws that, I know Professor Winikoff has been working really hard on that in the US about restricting the sale of these e-cigarettes to adolescents and youth. All these policy implications, along with us working in the clinical setting, hand in hand, would help reduce the exposure of cigarettes, e-cigarettes, or these substances in the population.
Thank you very much. The floor is back to the product. Thank you.
The opposition will be continued by Professor Wasserman, member of the assessment committee. And Professor Wasserman is Emeritus Professor of Pediatrics at Burlington University. Professor Wasserman.
Thank you. Thank you, dear candidate, for this absolutely excellent presentation and for your highly impressive work on dual use and e-cigarette use. I come from the perspective, like several of the other members of the assessment committee, of the practitioner. I have, based on your research findings, I have two questions, the answers to which I might have hoped to see in chapter 7, the general discussion, or in the thesis summary. The first is, and some of this has been already covered in your responses, but I'll ask it anyway. How can child health professionals who see families where parents are dual users make best use of the very, very limited time available in face-to-face visits, especially in the context of other screenings that are becoming typical in visits with families, like depression screening? And specifically, might there be advantages to implementing brief, regular, non-contemporaneous interactions with parents, perhaps through texts?
Thank you very much, highly esteemed member of the committee. Your work with children, your work in the pediatric settings is something that I have read and has always inspired me. So thank you for all that you've done. But great point about how do the clinicians address it. For example, when I presented SEAS or addressing tobacco use to my friends or colleagues in the pediatric setting, they were like, well, I don't have time. I have 10 minutes to see these patients. I am not going to spend 5 minutes or 3 minutes on smoking cessation. And we as in the SEAS team have worked really hard. And as I mentioned, we have worked on integrating the pre-visit screener now in the IEHR, which is the electronic health record system of the child. In the current version of SEAS, the pre-visit screener is sent to all the parents before the visit of their child in the primary care setting. They are given an opt-out strategy for nicotine delivery, nicotine NRT prescription delivery, quitline referral, or smoke-free text connection. And if they identify as smokers and they do not opt out, even before seeing the clinician, they are sent a prescription they are sent NRT, actually, not even a prescription anymore. They are sent nicotine replacement therapy delivered to their door. They are enrolled in the quit line. Someone calls them within 48 hours of their visit to connect them to the quit line, offer the counseling services, which are evidence-based, and they get a text from the smoke-free text service that they are connected and they are ready to be supported by them. So all this is happening without the clinician spending any time with the parent. What clinician does or does during the visit is up to them, is up to their level of enthusiasm. But even if they don't do anything, these parents are still getting the services that they want to quit smoking.
Thank you. That is very helpful. I have one more question. Do I have time, Prorector?
Yes, yes. Go on.
Okay, so you wisely mentioned the need for policy changes in your general discussion. And many health professionals are interested in political advocacy and are willing to take this on. How can those health professionals who wish to advocate politically best focus their efforts with respect to e-cigarette use? And specifically, what political alliances can they make to be most effective in changing health policy?
Thank you, highly esteemed member of the committee. I would say they should take a lesson with Dr. Winikoff, who has been advocating for e-cigarette use for a long time. But coming back to the question that, yes, we as healthcare professionals have the responsibility of not only taking care of our patients in the clinical setting when they're coming in, but in the whole community outside and advocating for their rights. For example, the smoke-free home laws, the multi-unit housing laws, for that we started with just the letters to the landlords about how smoking and secondhand smoke is bad, is not good for health. And just going on, showing them the evidence, presenting the evidence on how someone's smoking is affecting the children's health. And eventually, the persistence of presenting the evidence at every forum, starting from the community level to the legislation level, we need to present evidence, advocate for it. And for example, the Tobacco 21 law, we had to, there was a whole community movement around it, with starting from small counties, moving on to states, and eventually when the momentum picked up, when people understood the importance of when people understand the importance of these topics, these changes happen and policies are changed. So start from the small level, go on to the higher levels for the change.
Thank you very much. I congratulate you, dear candidate, and I have no more questions.
Thank you. The opposition will be continued by Dr. Van den Brandt, researcher at the Maastricht University and particularly at the Department of General Practice. Dr. Van den Brandt.
Thank you. Dear candidates, first of all, I'd like to congratulate you and your team of supervisors with your beautiful dissertation. Obviously, you've studied an interesting and very important topic, but still I have some remaining questions that I'd like to ask you. And the first one is about Chapter 6. Where you did a cluster randomized controlled trial of the thesis intervention. And I saw that it succeeded at promoting that parents who smoke received smoking cessation treatments. But on the other hand, there was not a particularly high change in smoking prevalence among the parents. So I was interested, would you conclude that thesis intervention was successful or not, and why?
Thank you, esteemed member of the committee, for your question. I read your work about smoking cessation treatments or smoking cessation interventions, where you have the results where you show that financial incentives for medication really help with cessation. A different analogy here, we focused on the child health incentives here to help parents quit smoking. With respect to the results of the trial, yes, the difference was small, but keeping in mind it was a population level prevalence. The percentage was a population prevalence. We took the risk this time to see, instead of a small cohort, seeing if a group of people quit smoking, we saw if this intervention can make a difference in at the population level. And indeed, we did see the difference. We saw that in the intervention practices, the smoking rates based on self-report went down from 27.1% to 24.4% 2 years later, whereas we did not see that decline in the control practices. Imagine that at the population level. I think it was successful, because even if we manage with an intervention, which is really low touch, but has an effect like this, we would be getting good results at the population level, and it's a success, I would say.
Yeah. So yeah, my follow-up question was, if you find it more important to reach more smokers with a less effective intervention, or to have maybe a more effective intervention with which you can reach maybe a little less smokers, but more effectively. So would you consider adapting your intervention a little bit to try to make it more effective? And what are your reasons for or against this? And how would it look like? What would it look like, this intervention?
Thank you very much, highly esteemed opponent, for this question. And I wouldn't say that thesis is a less effective intervention. I would say it's a light touch intervention where we give the smokers the evidence-based medication, which is NRT, and connection to the quit line and smoke-free text. But your point about is it important to reach the population with a light touch intervention, or is it better to reach a smaller group of people with a really intense intervention, is really valid. My thinking is smoking has widespread implications. Smoking, dual use, the morbidity, mortality associated with it is huge, and it needs to be addressed at the population level. The more number of people, sometimes these smokers or dual users are a special population. They sometimes just asking them about their smoking make them feel like, may make them think about it. It could be something that small, or sometimes even extensive counseling may not make them change their mind and may not let them quit smoking. But I think it is really important we reach the masses, we bring out our message to everyone about smoking or dual use or these products not being good for health, and promote the use of evidence-based treatments that are easily disseminable. The disseminable is key here because the intervention being easy, and that's what we have really strived for, worked hard for, the interventions to be simple, effective, and disseminable. And we have shown effectiveness with such interventions with our trial.
Yeah, so indeed, I can imagine that if you make the intervention more complicated, that it would be more difficult to implement for the healthcare providers. Thank you for your answer. I have also a question about your literature review in chapter 3. And I saw that you...
Thank you. Emara Nabi, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return.
Thank you very much.
Please unmute.
The degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Zegers is authorized to confer upon you this academic distinction in accordance with the Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Thank you.
I don't hear you, but you have to say, I promise.
I promise. Thank you so much.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Emara Nabi, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, now shown by the beadle.
Thank you very much. Thank you.
Dear Dr. Nabi, also on behalf of the Maastricht University and the Board of Deans, I congratulate you with the degree you have acquired, and the university wish you all the best in the future career. Hereby, I close this academic ceremony.
Thank you.